Hey, good morning and welcome to the show. I'm your host, Vic Sinise. Hope you're having a great day. We've got a great show for you today. UroNurse comes to you every Saturday at 9 a.m. Central Time. Never miss an episode. Hey, if you're watching us live, welcome to the show. I saw a few of you already checking in from all over the country. Glad you're joining us. If you haven't subscribed, please subscribe to the show. If this is your first time, and even if it's not your first time, be sure to check out our website at uronurse.com to find out more information about what's going on in the show. There's always helpful information. And after this show, that's when you'll be able to find information on how to get your free contact hour for today's show, because this will be a contact hour show. It's also the best place to go to see all of our past episodes, all 101 of those past episodes. So check them all out. And if you want to listen to your car, go right ahead. It's a great place to listen to the show. Every week we put out the same episode in an audio form. Click our UroNurse Plus area. It'll take you to where you can go and hook up with any of your favorite podcasters and have it delivered to you every week as it comes out. So as I said, this is going to be a contact hour show. It's going to have on advanced nursing practice in prostate cancer management, clinical evidence, novel agents, and patient care. It's also a SUNA meeting that was this was filmed at. So, hey, it's really great to have everybody here. I'm your only expert for today, so I hope that there's no big questions, but I think most of these episodes that we're doing that have contact hours also have, the expert covering everything from the show, especially this area. I'm not a super expert on doing the advanced prostate cancer drugs because I haven't been involved in a lot of those. But anyway, feel free to ask any questions, and we've got an intelligent audience always that can help answer questions too. Summertime, I hope everybody's enjoying it. That's probably why you're not seeing some of our regular experts, because I've gotten a lot of information that they're all doing stuff. Who could figure anybody would want to go on vacation? Well, I'm going on vacation in a couple of weeks, and I'm heading west to all those, west is that way, to all those states up west that I haven't seen. And the only thing I'm worried about is I was looking at the route that we're taking, and we're driving through a lot of it. A lot of warnings about fire warnings. So I think it's been pretty dry and pretty hot out there. So, well, who knows? So if I survive this trip, then we'll see you again for another week. But anyway, enough of that. Let's go ahead and get our program going. And here we go now.
At this time, I have the opportunity to introduce our speakers for today, Dr. Leonard Gomella from Thomas Jefferson University and Dr. Shandy Houston from Wichita Urology Group, presenting today on prostate cancer. So I'll turn things over now to Dr. Leonard Gomella.
Great. Good morning, everybody. Thanks, John, for this introduction, and thanks to Plexus and our various sponsors for letting myself and Shandy spend a few minutes with you this morning. So I've had the pleasure of working on some SUNA meetings in the past, a little bit closer to home in Philadelphia, closer to South Jersey. So I know what a great organization this is and how much it contributes to our specialty. So these are my disclosures. Shandy has no relevant disclosures. We have support of unrestricted grants from the companies listed here. And again, we're grateful for this opportunity to be with you here in Phoenix. So we got a very packed program, and I really think that we're going to give you, those of you that work in the advanced prostate cancer space, the best capsule, up-to-date summary of what's going on in the field. And we're going to go over all the four main disease states, from metastatic, castrate-resistant, through castrate-sensitive, through non-metastatic, and then finally the castrate-sensitive space. So hopefully we'll get some of the concepts of the latest clinical trials that are directing what we do. And then Shandy will hopefully fill in a little bit of the critical nursing support needs for these patients. So I'm a urologist and often get ask the question, why is a urologist talking about advanced metastatic prostate cancer? Well, I consider prostate cancer to be a team sport today. It's very different than it was 20 years ago. All of our patients at our Sidney Kimmel Cancer Center are seen by medical oncology, radiation oncology, urology, genetic counselors, and we devise a plan. Sometimes urology will follow the patients with advanced prostate cancer. Sometimes it'll be medical oncology. So again, I really think it's become a team sport. We're not siloed anymore as we were many years ago. So these are the big buckets that we're going to be talking about. Talk a little bit about epidemiology. We're going to talk about overview of the available agents that we have for advanced prostate cancer. And lastly, we're going to run down the specific non-metastatic castrate-sensitive, metastatic castrate-sensitive, non-metastatic castrate-resistant, and finally the big dog in our field, which is the metastatic castrate-resistant prostate cancer. And in between, Shandy is going to present some cases and get some ARS responses. So again, prostate cancer. Big problem in the United States. It's the leading solid tumor in men and the second leading cause of cancer death in American males. And it's about 30% of all new cancer cases in men. We have some disparities, as everybody is aware of. It's 1 in 8 for white men in the United States, but an incidence of 1 in 6 for African Americans. And unfortunately, in spite of our best efforts, African Americans continue to have a higher mortality. And the median age of diagnosis is around age 66. When you look at the death rates, about 11% of the estimated cancer deaths in men are due to prostate cancer. The numbers are a little bit misleading. It's a 1 in 41 lifetime risk of dying from prostate cancer, but when you get down to a day-to-day basis, there's a man dying every 15 minutes from prostate cancer. We had a little bit of a problem this year. We've done great in many areas of cancer in oncology, such as cervical, but we actually went backwards in prostate cancer, and we think a lot of that had to do with the confusion from the United States Preventative Service Task Force about screening, not screening for prostate cancer, but hopefully we'll be changing that in the next couple of years. So again, the incidence of prostate cancer rises greatly after age 40. Today it is most commonly detected as in low-risk disease. Many of our patients today are treated by active surveillance, as you know. We don't know the cause of prostate cancer. We know factors that contribute to aggressive prostate cancer, such as genetics, BRCA1, BRCA2, and the like. But we actually don't know the cause of prostate cancer yet. What's the trigger? But we know that certain things increase the risk of developing aggressive cancer, which are listed here. When we get to cancer early, you all know this, we have almost 100% 5-year survival rate, but once the cancer becomes advanced or metastatic, that survival rate at 5 years drops to about 32%. So prostate cancer is really not one disease. It's really a heterogeneous disease. Every man needs to have their prostate cancer screening as well as treatment personalized, because we have to figure out who to treat, when to treat, and of course the big question is, what is the best treatment? Is it observation, or should we simply treat the patient with active surveillance? So this is a familiar chart to many of you. We start with early localized prostate cancer. We treat it with radiation or surgery. Then, unfortunately, about 30 to 40% of men in their lifetime can have a PSA recurrence. And that PSA recurrence can go in different directions. Sometimes it's just a rising PSA with no evidence of metastasis. Sometimes it's a rising PSA which is newly diagnosed hormone-sensitive prostate cancer, and then, of course, each of those states can move further, and unfortunately, men die from prostate cancer, usually with metastatic castrate-resistant disease, and we certainly want to interact much, much sooner before men get all the way over to the right-hand side of that slide. So these are the 4 big classes that we're going to be talking about. We'll go to each one of the clinical states of prostate cancer and focus on how the diagnosis is made, but much more importantly, what is the treatment for the men with these different classes of prostate cancer. So one of our big challenges with advanced prostate cancer is the identification of metastatic disease. This is the hallmark when we make different decisions for different treatments that we're going to be talking about, the different disease states. But clearly, all of you know, PSMA scans have been a home run for us. They have probably been one of the, probably almost as revolutionary, I think, as PSA was in the early 1990s. We're picking up metastatic disease ways that we've never picked it up before at extraordinarily low levels of PSA, sometimes less than 0.05. So a lot of what we're going to be talking about is not based on PSMA scans, because you have to realize the PSMA scans have only been available for about 1.5 years or 2 years now. Most of the clinical trials that we're going to be talking about were either in process or completed when PSMA scans. So I want to throw that as a caveat. PSMA scans are going to be changing a lot of our management approaches. So I want to do a quick rundown of the available agents in advanced prostate cancer. Now, I'm using the term advanced prostate cancer because it goes all the way from someone who simply has a rising PSA after radical prostatectomy and no metastasis, all the way through metastatic castrate-resistant disease. So I'm kind of using this as a big bucket to refer to advanced prostate cancer agents. Of course, everyone in this room knows ADT is the foundation for almost all treatments of advanced prostate cancer. And we know that there's a whole bunch of ways that we can lower testosterone to treat advanced prostate cancer. Our goal is a testosterone of less than 50 nanograms per DL, but some data suggests if you can get it down less than 20, the patients tend to do better. But the big thing now, as you all know, being in the world of urology, is monotherapy with ADT is almost going away. Almost always today, we're taking ADT, we're taking the leuprolide or a hysterelin or Degarel-X and adding something on top of it. And that's going to compose a lot of what we're going to be talking about this morning. Surgical orchiectomy is still out there. It's not done commonly in the United States, but certainly in resource-poor environments outside the U.S., it's done very commonly. Anti-androgens pretty much don't have as much of a role as they used to. So this has been an amazing journey for us. If you look at the FDA-approved agents since 2023, you will see it's almost like somebody shot a starter gun back in 2010 with cabazitaxel and sipuleucel T all the way through 2023. And if you notice as we shift to the right-hand side there, many of our newer agents are associated with diagnostic tests such as genetic testing, and we'll certainly get onto that a little bit more. But clearly the big advance has been PARP inhibitors and certainly the use of lutetium in the treatment of advanced prostate cancer, which we'll talk briefly about later. So these are the approved agents in kind of big chunks here, from androgen pathway blockers, immunotherapies, cytotoxic therapy, DNA damage, and biomarker driven. And I'm just going to give you one slide on each one of these to sort of frame our discussion this morning. So the androgen pathway blockers, abiraterone, enzalutamide, apalutamide, and darolutamide, all interfere somewhere along the line of the androgen regulation pathway, whether it's outside the cell, inside the cell, or inside the nucleus. Very effective agents that have been pretty much of a breakthrough for us in the management of advanced prostate cancer. Immunotherapy has been with us for a long time. Immunotherapy has kind of risen and fallen over the years. When a new paper comes out that shows it has utility, it gets a little bit more uptake. But in general, probably not used as much as it potentially could be. And again, everyone knows that this uses the patient's own leukapheresis antigen-presenting cells, genetically modifies them, and then reinfuses them back into the patient over about a 3 to 4 week period. Cytotoxic chemotherapy, again, docetaxel was really a hot drug from the early 2000s, and it's still a very hot drug today. And again, cabazitaxel likewise is the same family as docetaxel, and this is systemic IV therapy that interferes with microtubules in the cell, in the DNA level, and resulting in cell death. DNA damage, this is radium-223. Again, this is something that is particularly effective at treating metastatic bony disease. As you all know, it doesn't do too much for soft tissue metastasis, but for bony metastatic prostate cancer, it's very effective at palliation and also extending survival. Pembrolizumab, I think you all know, I think we're up to about 18 or 19 approvals of pembrolizumab at this point. I think they'll be putting the drinking water one day. It's been approved in so many different cancers, not only GU cancers, but many, many other cancers. And again, what this does is this interferes with the T cell's ability to turn itself off, so to speak. It kind of takes the brakes off the immune system. And while a tumor tries to block the T cell from killing it, what the pembrolizumab does, it interferes with the mechanism of the tumor cell turning off the T cell, blocks that PD-1 and PD-L1, and then allows the T cell to kill the tumor cell. PARP inhibitors hit us like a ton of bricks about 3 or 4 years ago. We now have 3 different PARP inhibitors included and approved in prostate cancer. And this is this weird concept known as synthetic lethality. And no matter how many times I try to figure out a slide that shows it, here's the bottom line. What happens is that if you have damaged DNA, normally BRCA1 or BRCA2, when it comes in there, will try to heal that damaged DNA. If it's mutated, it can't heal it, so what happens is the cell kind of goes off on its merry way, ignoring all the normal development and doubling processes of the tumor. However, what happens is something known as PARP comes in as like a rescue and basically takes that mutated gene, sort of replaces its function and allows that cell to grow. Well, if you put a PARP inhibitor in there, basically you sort of kill the rescue mechanism, and that's a concept known as synthetic lethality. I can't figure out a good slide to show that, but explaining it is that it allows the PARP inhibitors basically allow a cell that has a mutated, out-of-control pathway that the salvage that allows it to continue to grow shuts it off, and that's what's known as a PARP inhibitor. Lutetium-177, one of our newest agents that we have out there for advanced prostate cancer. It's an IV agent. It's a nuclear medicine agent. It has to be only given if somebody has a positive PSMA scan, and it's only available now when you fail just about everything else. Although, again, it's probably everything is going on, we're going to start using it earlier and earlier, and in fact, it is being used earlier and earlier with current clinical trials. Again, very prominent molecule. It works very different than radium-223, just slightly different mechanism of action. So that gives you sort of a one slide a piece on the different agents. Now what we'll do is start talking about advanced prostate cancer treatment options, and we'll try to review with you the latest clinical trials that are setting the stage for guidelines such as NCCN, ASCO, and AUA for treating advanced disease. So this is, again, we'll see this slide over and over again, and each time we will focus on one area. So the first thing we're going to talk about is non-metastatic castrate-sensitive prostate cancer. What is this? This is a rising PSA after local therapy, either radiation or radical prostatectomy. The testosterone level is normal, but the PSA is going up. The standard imaging does not show metastasis. Now, I'm using that word standard because who knows how PSMA scan is going to change this in the future. But remember, the clinical trials that we're talking about are strictly based on standard MRI, CAT scan, and bone scan. So first up, we're going to talk about non-metastatic castrate-sensitive prostate cancer. So what is this? This is PSA recurrence after local therapy. We also use the expression PSA recurrence, biochemical recurrence. Again, standard imaging is negative. Based on the initial treatment, the definitions are a little bit different. If you've had a radical prostatectomy and your PSA starts to go up, the definition is a PSA of 0.2 nanograms per mil, which is going up on a subsequent test. For radiation therapy, there's something known as the Phoenix criteria, not because we're here in Phoenix, but because the original meeting about 15 years ago was actually held here in Phoenix at a hotel, and they came up with the post-radiation therapy nadir +2. So a little bit different for PSA recurrence after radiation. The Phoenix definition is the lowest PSA that patient achieved, and then when they have a increase of 2 or greater from that nadir, that's called a PSA recurrence after radiation therapy. So what are our options? If you've had a radical, you can do radiation. If you've had radiation, you can do salvage prostatectomy, cryotherapy, or HIFU. Of course, any of these you can give ADT if you think it's appropriate. If you have a patient with a long life expectancy, maybe you want to think about androgen deprivation therapy because it may give them the best chance, particularly if they have a rapid doubling time. If somebody is having a recurrence within 2 to 3 years of radiation or surgery, it is strongly suggested that they have micrometastatic disease, and you might want to think about giving them hormone therapy. So this is metastasis-free survival. So what are the bad things that can happen after a radical prostatectomy? But you can see here, Gleason score rules. If you've got a man who's had a radical prostatectomy with a high Gleason score, he's more likely to have a PSA recurrence in the future. Same thing as PSA doubling time is becoming very critical, and we'll talk about this later. Someone with a rapid PSA doubling time after radical prostatectomy is really in trouble. Radiation therapy, again, it's almost the same. High Gleason score, high clinical stage, and how quickly that PSA is going up. All of these suggest the person either has or will develop micrometastatic disease. Now, intermittent hormonal therapy, I think, has a lot of fans. I happen to be a fan of intermittent hormone therapy, and I'm happy that we've had several studies come out recently that really show that intermittent hormonal therapy for non-metastatic castrate-sensitive prostate cancer is non-inferior to continuous ADT. And I want you to look across the bottom there. We're talking about years after randomization. This trial was 10 years after it was randomized and basically showed after about 10 years, continuous androgen deprivation and intermittent androgen deprivation were pretty close to each other. So again, something to think about in certain patients. Again, I do this all the time, particularly with some younger patients as well. Now, we just had a big trial that got reported with a lot of attention in this space for non-metastatic castrate-sensitive prostate cancer. This was a trial that took androgen deprivation therapy, treated it alone, treated it with enzalutamide, and then treated it with enzalutamide alone. This is a very, very big study that I think is going to have significant ramifications for us going forward, because what this also does, this feeds on to this androgen deprivation plus something. So remember, this is early patients with prostate cancer. This is a rising PSA after either radical prostatectomy or radiation and no evidence of metastatic disease. And the bottom line of this EMBARK study is if you started a man on enzalutamide and ADT early compared to just the standard, which was ADT alone, you will see, again, if you look at that, we're talking many, many, many years here. You're talking 9 to 10 years after, you'll see that the enzalutamide combination was much better than using just ADT alone. So I think this is going to have some significant implications going forward, because that's a pretty significant survival advantage. PSA progression, again, you'll see that consistently over the years, just the leuprolide alone, the PSA goes up. But if someone has enzalutamide plus the androgen deprivation, they really have a pretty significant advantage. So again, I think you're going to see this starting to take over a lot of our non-metastatic castrate-resistant prostate cancer patients. So what we want to move to next, I invite Shandy to come up and talk about a patient with non-metastatic castrate-sensitive prostate cancer and allow her to present a case.
Hello, my name is Shandy Houston. I'm a nurse practitioner at Wichita Urology Group in Wichita, Kansas, and I've been working in advanced prostate cancer for the last 5 years. We'll start with the first case, 71-year-old Caucasian male with high-risk non-metastatic castrate-sensitive prostate cancer, now with biochemical recurrence. He underwent robotic radical prostatectomy in 2018. Pathology showed Gleason 7, 3+4 prostate cancer. PSA was initially undetectable, and he started to have PSA rise in January of 2022 to 0.1, then up to 0.3 in July of 2022. He was offered salvage radiation at that time, but declined. January 2023 up to 0.6, and then July 2023, 1.1, with a PSA doubling time of 5.3 months, which is significant. Anything less than about 6 to 10 months is pretty rapid doubling time. We tried to get PSMA scan, but that was denied by insurance. So we went with conventional CT and whole body bone scan, which was negative for metastatic disease. So this would be a good patient, that'd be a good candidate for ADT with enzalutamide. Enzalutamide's dosed at 160 milligrams per day along with ADT. There's no food restrictions or need for frequent lab monitoring, so that is beneficial. It does interact with some of the CYP substrates, so we just have a good drug interaction checker and make sure that we check those. We found that most of the drug interactions, if you separate dose by 6 or more hours, then it doesn't interfere. But if the patient is on warfarin, they may need to have more frequent lab monitoring with INR. There is some risk of seizure with enzalutamide, even in patients who've had prior seizure. It's only about a 2% risk, so it still is a pretty low risk of that, even in patients with prior seizure. But if they're on seizure medication, just make sure you have that conversation with the patient. There is some risk of posterior reversible encephalopathy syndrome. Symptoms of that would be seizure, headache, lethargy, confusion. It does take an MRI of the brain to confirm that, but you would stop the drug immediately and then order the MRI of the brain. There's some risk of falls and fractures, so just, make sure that you talk to the patient about how things look at home, get rid of any rugs, use a nightlight at night. I like to watch the patients when they walk in, and then I always open the door for them and watch them walk out so I can see how good their mobility is. So we need to talk about walkers and physical therapy at home. How often should we repeat scans? NCCN guidelines say that we can consider repeating scans about every 3 to 6 months. With patients with non-metastatic disease, if the PSA goes down to 0 with treatment, in our practice, we would generally offer scans at least once a year or consider doing more frequent if there's PSA rise, if the patient is developing more symptoms, or if things are changing. I always tell the patient, we look at 3 things for progression. We watch the PSA, we look at the clinical progression of symptoms, how he's feeling, how he's doing, and then we watch the scans. With ADT, there are going to be some side effects, which is important for us as nurses to anticipate needs. This is going to be phone calls that are coming into the practice, coming into the in-office dispensing. The most common that people complain of are fatigue and hot flashes, and it's a very broad spectrum. Sometimes it's pretty profound, and some patients don't complain much about it at all. With the hot flashes, there are some medication things that we can do to help if they're bothersome enough for the patient to take medication. There can be some decreased appetite and some change of taste. Particularly, that's more with adding the oral oncolytics into the ADT, so just make sure the patient isn't losing weight without meaning to. There can be some memory changes, dizziness, diarrhea, joint pain, extremity weakness, and then there is some risk of cardiac disease. So if the patient's established with a cardiologist, I make sure they're seeing them regularly, and if not, I really encourage them to see their primary care at least once or twice a year for the annual lab monitoring. And then there is some risk of accelerated bone loss, so if we can help protect the bones with calcium and vitamin D and medication, then we'll do that as well. Bone health, consider a baseline DEXA scan. We can expect 5 to 10% decrease in bone mineral density within the first year after starting ADT. I always recommend that they go on a calcium and vitamin D supplement that's available over the counter. And then if they can get denosumab, then we would get that approved as well. If it's affordable, it does give them benefit as far as keeping their bone mass. If denosumab is started, there is some risk of osteonecrosis of the jaw. Generally, that's less than 2%, so I do make sure they have a dental exam ahead of time, and if they have any teeth procedures or mouth pain, then I would hold it. And then we do BMP to monitor serum calcium once every 3 months and hold it if the calcium level is low. weight-bearing exercise, and the cessation of smoking and alcohol. For the cardiovascular disease, as I said, if they're established with a cardiologist, I make sure that I add the cardiologist to the note so he's aware of the treatments that we're doing. There is some risk of weight gain with starting ADT, so I do tell the patient that up front, encourage daily activity to try to help keep the weight off, and if they're having a difficult time, they can get a app like MyFitnessPal and help do a food tracker as well. We monitor blood pressure, optimize cardiac risk factors, check labs with the primary once a year, and then encourage exercise. There are some changes in sexual function when we start hormone therapy, so it's going to decrease libido. There can be more difficulty getting an erection, so I do offer medication for that if the patient is interested. And then we discuss that there can be some risk of penile fibrosis, so if that's something that they're going to want in the future, then we try to be aggressive with it as early on as possible. We can offer PDE5 inhibitors, vacuum erection device, or trimix injections. Mood changes, obviously people can have anxiety and depression during the course of the cancer journey. I think the important thing is to see how it's affecting their life. If there's any kind of functional disturbances, then we can offer counseling. We have a list of few therapists that people can reach out to if need be. And then we can use venlafaxine. That can help both with the mood and also with hot flashes, so that can be of benefit. The hot flashes can be very bothersome. We can offer venlafaxine. Also, we have the progestins, Depo-Provera injection, or Magestrol. There is a 5% risk of DVT with these, so if I generally would start with venlafaxine. If that's not working, I would offer the patient Magestrol, but we do discuss that there is some risk of DVT with that. Gabapentin, and then black cohosh is available over the counter, and some people would say that they have some relief with that as well.
Okay, great. Shandy, thank you. Good overview of a lot of the management issues that we have with ADT. Next, I want to move to talk about metastatic castrate-sensitive prostate cancer. Very often, this is the first diagnosis of some men with prostate cancer. They've had no prior therapy. They have a normal testosterone, but their PSA is elevated. They go on to have a biopsy. They usually have high-grade cancer, and then unfortunately, standard imaging studies indicate metastatic disease. This is something we've made a lot of progress in. These are just a handful of all the different clinical trials that are now establishing how we treat men with metastatic, newly diagnosed castrate-sensitive prostate cancer. Traditional treatment has just been ADT for many years. Today, we now do ADT plus something. So the initial management of these men usually includes androgen deprivation plus something. And again, this is what's coming into all our guidelines as we speak. So the major advance of over ADT monotherapy, we had chemotherapy, docetaxel, very effective in men who present with a large number of metastatic lesions. Depending on which paper you read, 3, 4, 5, 7 metastatic sites is considered to be high tumor burden. Abiraterone in patients who are high risk is another trial we have. And lastly, apalutamide and enzalutamide for all men with castrate-sensitive metastatic prostate cancer is available. Now, this is just a quick rundown of the many phase 3 studies that now support the addition of an agent beyond androgen deprivation, and we'll try to hit a couple of these for you. Again, clearly for most high volume disease, probably chemotherapy or abiraterone is the best choice. Low volume disease, it probably don't need to be as aggressive. You can add some other oral agents on as opposed to systemic chemotherapy, but we'll talk about it in a minute. This was one of the big breakthrough studies actually going back to the early 2000s, where adding docetaxel in addition to androgen deprivation extended survival of men, particularly with high volume metastatic disease. Charted was another clinical trial. Again, if you compared ADT versus ADT plus docetaxel, high volume disease, it made a big difference. For low volume disease, probably adding chemotherapy on doesn't help these men that much. However, if you look at the Stampede trial, the overall survival in men with metastatic disease that you added abiraterone and prednisone, actually it did extend extend survival very significantly. Stampede, abiraterone versus docetaxel, again in M1 and M0, there was really no big difference in the two when all patients were taken together. Another trial you're going to hear about is called the Latitude trial that, again, looked at ADT plus abiraterone versus ADT plus a placebo. And again, significant advantage in overall survival. Again, reinforcing this concept that ADT plus something is probably representing the standard of care today in these groups of men. Something called the Titan trial. Again, pretty much the same group of patients, but in this particular study, you added a drug called apalutamide. And again, if you look at the overall survival, the median has not even been reached yet. And I want you to go across the bottom there. You're talking 4, 5, 6 years. So I want you to get the impression that men are living a lot longer. The data says once you have metastatic prostate cancer, traditionally, you're going to live 2 to 3 years. I think now we're pushing that up to probably 5 or 6 years using these new treatment approaches that we are developing. Again, significant reduction in the risk of death. And again, the right hand looks a little bit better because that was for crossover. Men who were progressing on this placebo trial were able to get abiraterone. Again, 35% reduction in the risk of death. With the crossover, almost 50% reduction in the cancer death around 4 to 5 years. Enzalutamide versus non-steroidal anti-androgens. Those are our good old standby friends, bicalutamide, flutamide, that we basically kind of don't use too much anymore. But again, this study showed us that enzalutamide was much better than non-steroidal anti-androgens added to ADT in this group of patients. Again, another trial, ARCHES. These are hard to keep up with all the different names, but again, this was an enzalutamide-based trial, purely enzalutamide, again, showing a survival advantage. So what's happening now with androgen deprivation therapy and metastatic castrate-sensitive prostate cancer? We're adding one agent on to ADT. Well, how about adding more agents on? And that's really what's going on right now. Now we're sort of piling on more and more agents. Probably one of the significant trials that came out over the last 1 to 2 years is something known as the PEACE-1 trial. And essentially what the PEACE-1 trial did, it added a lot of things on to men with castrate-sensitive prostate cancer. There were many different arms of this particular trial. It was sort of a basket trial. But essentially, what this showed was whatever standard of care you used to treat that patient, whether it was with abiraterone, with enzalutamide, with enzalutamide, if you added abiraterone on, again, you extended the survival. And again, look at that line across the bottom. That's 5 years, showing again that we're really doing a lot to extend the survival of these patients. Again, the standard of care plus abiraterone for high volume disease was a benefit. If you look at low volume disease, again, this is up for you and the provider that you're working with to decide. Low burden, high volume, low volume. Again, sometimes for the low volume disease, more is not always better or doesn't really add anything on. Lastly, in this area of adding on, one of the latest trials that was reported is known as the Arisens trial, which now took ADT plus docetaxel plus darolutamide. So it added now 3 things on, ADT, docetaxel, and darolutamide. And again, you can see a pretty significant reduction in the risk of death. So this is the direction we're going in, that maybe more is better for a lot of patients. So we have a lot of clinical trials out there that support improved overall survival with agents, whether it's docetaxel, abiraterone, enzalutamide, apalutamide. But again, tends to be a little bit better for men with high volume disease and maybe not so much for men with lower volume disease. So now that we've gone all the way in that extreme, we're probably going to start coming back now and figuring out how can we do less, because obviously there's financial toxicity and also the potential for additional clinical toxicity for some of these patients. So what do we see here in the NCCN guidelines for systemic therapy for castrate-sensitive prostate cancer? You can see there's a lot of choices in there now: abiraterone, apalutamide, enzalutamide, but all ADT plus something. And again, they still do maintain ADT as monotherapy, but I think that most of us realize that we want to bring the best benefit to our patient, and adding a second agent on is probably going to do that. So next, have Shandy come back up and now talk about a patient with metastatic castrate-sensitive prostate cancer that we just reviewed.
So we have a 52-year-old Caucasian male with metastatic castrate-sensitive prostate cancer, presents to the clinic with a PSA of 235, firm prostate. He had a prostate biopsy showing Gleason 9, 5+4 prostate cancer, which is grade group 5. He had a CT scan showing retroperitoneal and pelvic lymphadenopathy, and a bone scan showing a super scan. So essentially, the whole bone scan lights up. He had germline and somatic testing, both of which were negative. So for this patient, he's going to receive upfront ADT, docetaxel, and darolutamide. If he had oligometastatic disease, so less than 4 sites, less than or equal to 4 sites, then we could consider doing ADT and oral oncolytic along with radiation to the prostate and the sites of metastatic disease. If that were the case, then we would do ADT and the oral oncolytic for about 2 to 3 years, and then at which point we could stop and see, if the PSA rebounds. In a patient like this, I would tell the patient up front that we don't expect for him to have full cure once that the cancer's outside of the prostate, but we could try with radiation. Toxicities can increase with the extra added on medication, so just be aware of that. With apalutamide, probably the biggest thing would be the rash. I don't see that super commonly, but it generally clears up with topical steroid cream or an oral steroid, and then we can re-challenge once the rash has gone away. With triplet therapy, the darolutamide is going to be 600 milligrams twice a day with food, must be taken whole. There's not a lot of drug-drug interaction, so that part is nice. And the side effect profile is very good, so it's very well tolerated in patients. There can be some decreased appetite, some weight gain along with the ADT. And if they have renal or hepatic impairment, then we would consider dose reduction, and we generally would check with nephrology before we would prescribe full dose in that case. The first chemo should be started within 6 weeks of starting the darolutamide. Upfront docetaxel is given once every 3 weeks for 6 treatments. With that, the patient will have some fatigue, weakness, nausea, vomiting, stomatitis, neuropathy, nail disorders, anemia, thrombocytopenia, leukopenia. Oncology is pretty good about managing a lot of that, but we do see the patients in office for PSA checks during that time, so we always check in and see if there's anything that we can do to help. So this is our same patient. And now he decides he wants to stop all treatment due to having severe hot flashes. How can we manage his complaint? A, refer him for acupuncture. B, start venlafaxine 37.5 milligrams a day. C, start magestrol 40 milligrams twice a day. Or start zolpidem for sleep.
Well, that's actually the end of the show. That's where the clip ended. So, hey, I took I guessed the 3 or C on it for the treatment. If you have any questions, feel free to put those questions into the comment area or comments. How did you like this? That things like that would be interesting to hear. Again, I'm the only expert for today, and this is not my expertise. I'm one of the guys that have been around long enough to mostly have been treating people with ADT. So I'm of course aware of these other drugs. And 2 or 3 episodes ago, Dr. Berger spoke about the enzalutamide. So you can look back to that to learn more about that particular drug. Hey, Fran, thanks for the excellent presentation. So yeah, during the summertime, I've been trying to come up with some of these contact hour things. I thought I checked with the company. They're happy to let me do this. And I thought it's a nice way to get those extra contact hours that some of us need for keeping up with our your CURN, or whether you need it for your state license, all of the above. It's always a good idea. And I think it's just good to keep up on everything. Even though I don't do a lot of get involved with the chemotherapies and things myself, it's always good to know about it because, hey, who knows, someday I might be a patient. So, all righty. Hey, Donna, welcome to the show. Okay, excellent presentation. I like to take credit for it, but of course that came through from Suna. So that was at the Phoenix meeting they recorded it from. I like this approach to certain topics. Yeah, thanks. I'm glad you're appreciating it, because again, I'm always out there looking for speakers and ideas for UroNurse to keep the education part going. And I thought this was just too good to pass up. So we'll have some more of those. So let's go on to our extra stuff here for next week. We're going to be switching over to our typical format of live speaker and experts. And I've got a really great speaker that I lined up. I think this is going to be interesting. Well, let me play the promo and then I'll talk about it.
Bill Decker, an investment advisor representative, presents a comprehensive guide tailored specifically for healthcare workers in powerful income solutions, effective tax strategies, and valuable estate plan coordination. This resource delves into innovative ways to maximize income through diversified investment portfolios, providing practical tax strategies that minimize liabilities while optimizing returns. Additionally, it emphasizes the importance of meticulous estate planning to ensure the protection and efficient transfer of assets. Decker's expertise offers healthcare professionals a strategic roadmap to financial stability and growth, ensuring their hard-earned income is well managed and secure for the future. Learn more next Saturday at 9 a.m. Central Time on UroNurse.com.
Well, there you go. Great. So yeah, a little different. We're going to talk about wealth and, trying to maintain your wealth. Now, of course, I'm at the point in my life where, I'm kind of pretty close to being completely retired. But, I think that, for you younger folks out there, especially, knowing how to start investing and putting away for the future is huge. If you don't make the right investments, when you get to be my age, you're going to be kind of out of luck. So I thought this would be a good one. This guy I met through LinkedIn, and he sounded super interesting. I thought this would be great to learn more. So, and I got a few more comments coming up. I like the approach to the show. Very good information, well presented. They really, really appreciate Nancy. Appreciate the CEU opportunity. Tabo, you're welcome. All right. So with that, I'm good to let the show end a little early and get on with things. Couple reminders at 10:30. If you are a patient watching this, God help you if you were a patient watching that. I struggle to keep all this stuff down. But anyway, if you're a patient and you want to learn more about patient side, check out our europatient.com for our Europatient podcast, which comes every Saturday at 10:30, follows this show shortly. And we'll be going to that one. And the rest of you have a great rest of your summer. And we'll see you next few episodes. Like I said, we're going to be coming live. Got lots of great ideas to share with you guys, starting with that investment one. So with that, have a great rest of your day. And we'll see you all next week on UroNurse.